is Dr. Tabbaa, who's here. He is our incoming president of NEOLA, so he'll be presenting on the great topic of liver cancer for you today. Thank you very much.
Thank you. Yeah, I'm not sure I'm going to use a microphone. It seems like everybody using a microphone, but doesn't work. Does everybody hear me okay?
Use the microphone.
Use a microphone. For you, I'll use a microphone. I have to listen to Dr. Carey, whatever he tells me. Listen, I was given this task and I wondered why. And when I looked at the abstracts, I even wondered why 10 times. When the majority of the abstracts are bench-based, biomarkers are easy, but when you talk about DNA mutations and things like that, and you go into bench studies in liver cancer, and then you talk about chemotherapy and immunotherapy. So I decided to choose, like Dr. Chang was mentioned, really topics that are relevant to my practice, and I'll focus on these. With that said, let's move to the slides. So the first study is a comparative risk of hepatic decompensation and hepatocellular cancer among anti-diabetic therapies in type 2 diabetes in patients with a chronic liver disease. So if you have type 2 diabetes, you have chronic liver disease, which anti-diabetic agent would you use? And the reason for this study was the fact that the safety of second-line treatment of anti-diabetic medication has not been really well established, and the idea is that therapies that available to us may not have the same impact on liver disease. So whether you use SGLT2s, GLP-1s, or DPP-4, or sulfonylurea, what's the outcome? And just to remind you, for those of you who don't treat a lot of diabetic patients, in terms of diabetic class medication, here we go. When you look at SGLT2-1, which is the sodium glucose, you're talking about anything that ends with glycosine, which is a bit like the Jardiance and Farxiga. When you look at GLP-1s, we are more familiar with them, like Mounjaro, Ozempic. When you look at DPP-4, there are things which are leptin, so Januvia and things like that. So the study basically looked at retrospective analysis, both in the United States and Korea, looked at adults more than 18 of age, and who have type 2 diabetes associated with chronic liver disease, who had therapies for a period of 10 years between 2013 and 2023. They excluded, obviously, patients with decompensation and HCC. They had 21,951 eligible patients. MASLD was clearly the predominant etiology of liver disease. And basically, the conclusion was the fact that in SGLT2s, the hazard ratio of versus sulfonylurea for hepatic decompensation was 0.57%, for GLP-1 was 0.68, and the same thing with when you look at DPP-4 versus sulfonylurea, the risk was for SGLT2s versus DPP-4, the risk was 0.5% for SGLT2s, and for GLP-1 versus DPP-4 was 0.6. So both the SGLT2s and GLP-1s were safer, significantly safer to use in terms of less likelihood of developing hepatic decompensation. In terms of hepatocellular cancer, the same held true. SGLT2s and GLP-1 were safer versus sulfonylurea. So both therapies work, and the conclusion of the authors were that SGLT2s and GLP-1 reduce risk of hepatic decompensation and HCC. They outperform sulfonylurea and DPP-4, and that support the preferred use in high-risk liver disease. I think this is a take-home message that's important to educate both our primary care physician and patient and endocrinologists in patients who have underlying liver disease and diabetes. The second study is basically looked at biliary tract cancer and whether the use of aspirin versus Tylenol increase or decrease the risk of that disease. The study came from a nice group that I wasn't aware of called the Biliary Tract Cancer Pooling Project, or BiTCa. And what they tried to see is NSAIDs, which have been associated for many years with the reduced risk of several cancers, whether it does reduce the risk of cancer of biliary tract, and what also the story with acetaminophen, since we tell our patient with liver disease use Tylenol versus NSAID very frequently. The biliary tract cancer include gallbladder cancer, extra and intrahepatic cancers. There are these 13 prospective studies that pulled together. They did Cox analysis on them. They looked at 19,000 patients. Gallbladder cancer cases were 494 cases. Intrahepatic cancer was 339. Extrahepatic cancer was 499. And ampulla of Vater cancer was 291. And basically, it was the conclusion of that retrospective analysis that the NSAID intensity, when increased, i.e. when you use NSAID in general, there was decreased incidence of extrahepatic biliary cancer risk with the p-value of 0.04, and the aspirin decreased the risk of intrahepatic biliary cancer, again statistically significant, while interestingly increased acetaminophen use result in increased both of intrahepatic and extrahepatic cancer. I think as we are advising our patient that we have to keep that in mind if they have primary sclerosing cholangitis and we're monitoring them for cholangiocarcinoma. So the conclusion of the study is obvious. NSAID may reduce the risk at Tylenol or acetaminophen. Tylenol has been a lot of bad publicity lately, but may increase the risk of intrahepatic and extrahepatic biliary cancer. The next study is the de novo malignancy after liver transplant for HCC. We're gonna hear in a minute, and I'm sorry, Dr. Khalil, about keeping you a little waiting here, but I started a little bit late. But basically, after liver transplant for HCC, the malignancy incidence for certain cancers may not be the same as patients who are transplanted for non-HCC causes. So the purpose of the trial here is to really look at that. So looked at, the data was so far limited. In this retrospective analysis that came from TriNetX, which is 68 health organization, they looked at two cohorts, liver transplant with HCC and liver transplant without HCC. They matched them both for demographic, viral hepatitis, tobacco use, and other comorbidity, and they looked at the de novo malignancy after transplant. The higher risk was noted in bronchus and lung cancer. It was actually 207, so twice as likely to get lung cancer, and also the prostate cancer was 1.5 times more likely. The implication of that, the important part of that too, is that when you look at colon, pancreas, esophageal cancer, stomach cancer, and other cancers, they did not differ. So the conclusion that maybe the intensity of surveillance for these two cancers might have to be different after liver transplant for SCC. Okay, now we're gonna go into probably the last three, but very important abstract that I wanna spend time on. And the reason is basically, I was told by Dr. Curry many times that surveillance for SCC is very miserable and remains miserable. And we try to improve it every time. So we came up with different methods, different markers, and the landmark study that I will discuss later is this basically the MET DNA, which we'll talk about in a minute. But before we go there, let's look at the performance of GALAD, GAAD, and ASAP in early detection. This is an abstract that looked at the fact that yes, our biomarkers like alpha-fetoproteins are poor, ultrasound is not enough. We want to detect hepatocellular cancer before it's advanced so we can treat it better, we can cure it. And so they looked at a period of 14 years at 44 trials and 33,100 patients and looked at the basically different random effect model. If you want to be reminded what these are, GALAD is combination of gender, age, alpha-fetoprotein, and 3 and DCP. GAAD is gender, age, AFP, and DCP. And ASAP is age, sex, AFP, and BiTCa. And there is sensitivity about 70%, very similar for the three composite markers. And there was no significant difference between either one of them. And the sensitivity was similar to that of ultrasound. When you combine those markers with ultrasound, you pick up that more likely earlier. The problem it is retrospective analysis, variable biomarkers cutoff were noted in different studies, and they included also non-cirrhotic patients. Now, This is a study that Binu Jean presented as a breaking session on Tuesday, and he asked me that it should be my main presentation. So he sent me, Binu sent me this. And I did not do a disclosure, but the main disclosure that we do participate in Exact Science clinical trial for colon cancer. This is for hepatocellular cancer. So this is the performance of multi-target blood test versus ultrasound detecting early hepatocellular carcinoma, results from the ALTUS trial. ALTUS is alternative to ultrasound prospective study. So ultrasound, we know it's limited, as I mentioned earlier. It's really, the problem is detecting stuff early, and the estimated the detection now is only about 36% for early cancer. It's very operator dependent, and there's all other associated issue. More importantly, as we heard repeatedly, there is poor adherence, and maybe if we simplify all of that, make it less operator dependent, make it more adherent, we can do something important. Blood-based molecular biomarker has been evolving, whether it's colon cancer, pancreatic cancer, liver cancer, and the multi-targeted HCC blood test, or MT-HPT, combines methylated DNA markers, actually 3 markers, combined with AFP, and try to detect early liver cancer. So the ALTUS study is a prospective multi-center study. It is evaluated MT-HPT and followed by contrast CT and MR to really confirm whether these patients have it. The model of the study is very important. It's basically started with all adults with cirrhosis and chronic HBV. These patients will undergo surveillance ultrasound and MT-HPT, the blood test, or surveillance CT-MR and MT-HPT. Then basically they send the study to a central lab to decide what LRAD classification the lesion has, and they conclude if they detect the stuff early. The primary goal of the study was non-inferiority of MT-HPT to early stage HCC cancer compared with current methods. And the secondary is the overall HCC sensitivity of MT-HPT. And this is really the 2 most important studies. So MT-HPT here, as you see, the result is really remarkable. The blood test was 66% accurate in early stage cancer. This is cancer that meets Milan criteria, versus 22% ultrasound, AFP 20%, 25%. When I asked why is this so low, the ultrasound detection, he basically said this is one of the few prospective studies, and a lot of the ultrasound data come retrospective analysis. So really, when you combine even the ultrasound alpha fetoprotein, you are 66% versus 44%. Again, its specificity is excellent. And when you compare the overall any stage together, you still have 73% versus 27, 29, and combined versus 51%. So basically, the limitation of the study that it did not evaluate the longitudinal adherence over time. There was a small number of HCC patients included in the study, which by basic exclusion, and indeterminate imaging findings were excluded, which may basically weaken the study. The conclusion of the author was that MT-HPT sensitivity for early stage HCC, which is 66%, was 3 times higher than that of ultrasound. MT-HPT sensitivity for very early HCC, which is again 63%, was 7 times higher compared to 9.1 ultrasound and plus AFP. I think this is a very important thing we have to keep an eye on, and whether this is going to be the new standard the AASLD will put together in terms of screening for HCC for our population remain to be seen, but I would not be surprised. Now, the highlight of my last talk was I got a lot of these slides from Dr. Federico Acejo, and I'm thankful for him. I had no idea 6 months ago what histotripsy is. And I'm now so excited about it. I want the histotripsy, all my patients for every lesions, including benign lesions. So histo is histology, tissue. Tripsy is crushing, so crushing tissue. It's non-invasive ultrasound wave therapy that got FDA approved actually at the end of 23, and we'll talk about when got approved as part of therapies for HCC in a minute. So there's nationwide about 400 or more treated patients in the world, and slightly more in the United States. What histotripsy is a pulse sound wave that induces this bubble cloud from gases naturally present in targeted tissue. You ask what gases. So whenever we take a breath, that oxygen air we go, it has to go everywhere in the tissue. So actually within our cellular matrix, there's tiny, tiny bubbles, microns bubble of air. If you hit them with the ultrasound with the right frequency, that tiny bubble will expand and collapse, expand and collapse, expand and collapse, and that leads to just purely a mechanical destruction. The fascinating things about that, it mechanically destroys the tissue, but does not destroy the connective tissue between it. So if you have a lesion encasing a vessel and an artery, you can actually destroy the lesion and maintain the vessel. The difference between that and microwaving, by the way, or RFA, is really the frequency and the pulse rate. So if the frequency is lower, the pulse rate is less amplitude, it generates heat. If it is high pulse rate, high amplitude, and very short, it expands and collapses without generating much heat. So when you ask what the cloud is, this is under electron microscopy. That's what the bubbles look like under electron microscopy as you apply the technology. These bubbles are forming within the mass and forming this. If you take a piece of liver and expose it to this machine, this is what happens. There's a needle in it, and liquids start going down. So it liquefies your tumor. This is what happens in porcine valve before. Here's the liver tissue. Here's after applying the technique, and here's what you look. You see the tissue is gone, but the connective tissue is still there. So it's non-thermal, it preserves biliary and vascular structure, it's non-invasive. This is then, it was developed in University of Michigan. 20 years ago they started on it. Then it was adopted recently worldwide. A company, I think it's called Histosonics, bought that technology, and now they are re-implementing it in multiple centers. There's different hardware, but this is actually what the center looked at the Cleveland Clinic. This is what patient sits there under that machine with about an inch difference between their body and the machine that's applying the pulse. If you take a piece of paraffin or rubber and put a liver within it and apply this to it, this is what it looks like. That's what's going to happen. I'm going to speed it up a little bit. This is what basically, as it's monitored, they show you the pulse happening. This is the waves as they're hitting, and at the end of the treatment, which takes about a few minutes, you go in and you cut that paraffin and look at that piece of liver. And that's what's left. It's liquid, that's no acellular liquid that doesn't have any viable tissue in it. So currently the difficulty has been applying it behind the ribs, behind the lung, behind the bowel. So it has to be less than 15 centimeters away from the tissue. So where do you apply it to? It is, the scenarios is basically in the future can be for unifocal lesion, for oligofocal lesion as a curative intent. And of course, everybody wants to bridge the transplant if you want to eliminate one lesion and transplant the other. This is the before and after. This is actual patient, 88 patient with cirrhosis, had heart rate, had failure and renal failure, and had 4.5 centimeter lesion. The before and after. Clearly, a vacuum instead of a tumor that's enhancing. Same thing here. So the UNOS basically added this technology earlier this year in August to the multi-modality of treatment that we can apply for HCC. One effect which I wasn't aware of, sure for those of you who work in liver cancer all the time, is the abescopal effect, which I did not know initially about. Apparently, whenever you destroy tumor mechanically or by RFA, you basically allow the immune system to react to that. And by having the immune system to react to that, there's ironic response. The initial response happens, but then later response within 30 days, the antibodies that your body form attack the tumor again and get rid of more bad tumor, which is kind of interesting phenomenon. This is the 230 patients that were treated by mid of this year in different centers. And they're treated for different cancer, pancreas cancer, breast cancer, other cancer, and of course, HCC, 33 patients. These are the location of liver cancer patients that were treated, different segments of the liver, some complications. Actually, it's very safe. The vision, if you get into the University of Michigan website, the lady who invented this, last name XU, Shu, I think it says Zing Shu. And she basically, her vision and the vision team is this can be done outpatient in almost handheld device, which I don't know if it will happen, but it's ridiculously sound like Star Trek and Dr. Spock. I mean, it's just amazing. So they presented abstract this year about the local tumor control of liver tumor after histotripsy, which is preliminary national multi-center study. It reiterated basically what I demonstrated in these slides, showed the methods of the technology I showed, but this here, the two graphs illustrate the before and after radioactivity of the tumor, and the red is what's left of the tumor after one application. The green is what's completely gone. And basically, it is remarkable technology. The preservation of it is of the tissue surrounding it gives us a new really hope that we can treat this tumor. And I thought that would be a good conclusion for hepatocellular cancer talk. Thank you very much.